welcome to this teaching program. As per the discussion we have in interaction I have with you regularly in our students WhatsApp group, you all wanted for these couple of months purely to concentrate on practical in view of coming exams. As per your request, we have covered breast, oral cancer, and the tables, viva, also the specimens, then radiology, X-ray, CT scan, and instruments. So today we have a clinical case which is a mass per abdomen, and the exam going final year student Merlyn is presenting it, who is a DRNB final year exam going student from Pune. To do a mock exam, discuss with you, I have two very most senior surgical oncologists, not just surgical oncologists, this is one of their special area of interest, who are teachers par excellence, very senior professors, and who run a very good MCH and DNB teaching program, also an examiner for both MCH and DNB. So it's a great opportunity to understand, learn from them. At the end of the full discussion in the chat box and Q&A, please ask whatever doubts have. Don't worry how silly it is. Better to feel silly here, be wrong, than being sorry in exams. And as you know, this is a very major case. Breast, oral cancer, and a mass per abdomen would always be there. So please utilize this opportunity. Thank you very much, Raju and Sridevi, for taking time in your busy time. I know clinical work, your own teaching program, students, and a lot of hectic day, but great of you to take your time out for benefit of students and national board. Thank you very much. And Merlyn, over to you. All the best.
Good morning, everyone. I'll be presenting a case about a mass per abdomen. So my patient is a lady age 55 who came with a chief complaint of pain in abdomen since the last 1 to 2 months. It was associated with abdominal distension and loss of appetite. The patient was apparently asymptomatic 2 months back when she noticed pain in the abdomen. The pain was insidious in onset, dull aching in nature, and intermittent. The pain is more in the left lower abdomen. She had a pain score of 2/10. The pain was not associated with intake of food, was not associated with nausea and vomiting, and there were no aggravating or relieving factors. The abdominal distension was insidious in onset and slowly progressing since 2 months. She also complained of loss of appetite. The loss of appetite was associated with early satiety. The patient also complains of weight loss. However, she could not quantify the amount of weight she has lost. She did not give any history of any altered bowel habits. She did not complain of frequency of urination. There was no complaint of pervaginal bleeding or pervaginal discharge. She did not give any complaint of fever. She had no history of melena or perrectal bleeding. No yellowish discoloration of eyes and skin or pruritus. No complaint of cough, breathlessness or hemoptysis. And no complaint of back pain or bony pain. In the past history, she had no history of any previous medical or surgical illness. She underwent a tubal ligation after her second delivery at the age of 25. She had no history of any drug allergies, no addictions. She consumes a mixed diet. Her sleep, bowel, and bladder habits are normal. She does not have any history of malignancies in her close blood relatives, and there is no history of any other hereditary or familial disorder. Coming to her obstetric and menstrual history, she attained menarche at the age of 14 years. She was married at the age of 20. She gave birth to 2 children. Both were full-term normal spontaneous delivery. Her first child was at the age of 22, second at 25. She breastfed both her kids for a period of 2 years each. She does not give any history of consumption of OC pills or treatment for infertility. She had a TL at 25 years of age, and she attained menopause at the age of 48. So I would like to summarize my history saying that a lady aged 55, P2L2, with history of tubal ligation, presented with a complaint of pain and distension of the abdomen since last 2 months, associated with loss of appetite and loss of weight.
Yes, sir. So, Merlyn, from the history overall, what would you infer? What do you think the possibilities are?
So first, considering her age, and that the symptoms are of a very short duration, and also the frequency of the symptoms is more in the last 2 months. It could be a malignant etiology.
Okay.
Considering she's also a lady, the most common one in this age group would be from the genital system, from the ovary. It could be from the ovary.
From the ovary. So you're suspecting ovary because she's 55.
Yes, ma'am. And it could be endometrium, but she did not give us any history of any PV bleeding or PV discharge. So if that would also, if she had complaint of PV discharge or postcoital bleeding, we would also consider CA cervix.
CA cervix. Now that is trouble.
If she
cervix, no,
I would rule it out. Okay.
No. Just because she's a lady, you've listed ovary, endometrium, and cervix. So endometrium, you reasonably ruled it out because she had no vaginal bleed. So how do you get a cervical cancer that presents with ascites? What is the usual site of spread of cervical cancer?
To the parametrium and to the nodes.
Which nodes?
To the pelvic and the paraortic.
They're rarely present with
rarely, yes, ascites.
Okay, now outside of an ovarian cancer, can you give any differentials that can happen in this lady?
She could have a colonic.
Agreed, you have examined the patient, you know there's an ovarian mass.
She could have a colonic malignancy could also be there.
A colonic malignancy, okay. Okay, so you only want to give differentials for a malignant ascites, right? You wouldn't want to think of any other causes for ascites just because the history is only for 2 months.
Yes, sir.
So, Merlyn, if suppose this patient is a male, what are the things that you will consider?
We could consider cirrhosis of the liver, any liver malignancies, primary peritoneal malignancies.
Sorry, sir. You continue, sir. Continue.
No, go ahead. No, one is cirrhosis. Anything else? Merlyn?
Liver malignancies.
Only any other malignancy?
Primary peritoneal malignancies.
Okay. Anything else? Can this be a gastric cancer?
Yes, sir. Yes.
Can it be a colonic?
Yes.
So you keep all of them.
Yes.
You have to keep all of them into the attention, and then only because she's a lady you are biased. So otherwise, the same cancer can occur in a lady also. Okay?
Yes.
Okay. Go ahead with the physical examination.
Sir, just a few questions.
Yeah,
and you need to keep a mind of having a non-malignant etiology also.
Yes.
Okay, so what will be the non-malignant etiology differentials you will have to think about?
Tuberculosis.
Yes, it still happens in our part of the world. TB is real, it keeps happening. So you need to keep that behind. Okay.
Yes.
Now, in your history, you stressed a couple of times about tubal ligation. What is so important about tubal ligation in an ovarian cancer or suspected ovarian cancer?
So tubal ligation has a protective effect on against ovarian cancers.
How does it protect? You're only ligating the tube?
Considering how we've recognized that the etiology for ovarian cancers could be because of the cells which come out from the fimbrial end, the tubal cells which come out from the fimbrial end, tying up the tubes would prevent the coelomic spread of those tubal cells and therefore decrease the chance of ovarian malignancies.
So physically, you're interrupting the continuity of the tube.
Yes.
So that is the reason. Any other reason?
No, ma'am. That's the
reason. What about oral contraceptive pills? You said she had no oral contraceptive pills. What are the relationships of oral contraceptive pills?
So considering the theory of incessant ovulation, repeated ovulations causes repeated damage of the ovarian lining, and therefore there is metaplasia, which in turn can increase the risk of ovarian cancers. So, considering in OCPs there are no real ovulation, therefore it is protective against ovarian cancers.
What length of use of OCPs is known to?
More than 5 years. OCP consumption for more than 5 years.
So you need to use for 5 years for any kind of protection. Shorter durations don't
shorter.
protect.
It does protect. For 1 year, there is around.
So the maximum protection is for 5 years, but any duration of use is useful.
Would protect. Yes.
Now, this protection is for normal risk individuals and high risk, or only for high risk individuals?
For both normal and high risk individuals.
Okay. In your family history, you said patient has no close blood relatives with cancer.
Yes,
ma'am. Who are you referring to as close blood relatives?
The first and second degree.
Yeah, I think you need to specify that. Close
okay,
is a very,
yes,
it's a very relative term. So
okay.
Close can be 4 circles of cousins also. So I think that you just specify there's no first and second degree relatives.
Yes.
So what specific malignancies did you ask for? Besides
breast cancer.
Okay.
Breast, colonic cancers.
Mm-hmm.
Thyroid, pancreatic cancers.
Thyroid and which syndrome are you looking at? And pancreas, which syndrome are you looking at?
In Lynch syndrome and BRCA syndrome also there are some cases. There patients do have an increased risk of endometrium, ovarian, thyroid and pancreatic malignancies. Okay,
so she doesn't have a family history.
No, ma'am.
Right. Now, how often you get hereditary cancers in ovarian? In 100 ovarian cancers, how many of them have a mutation?
Around 15%, ma'am.
15%. Okay. Okay, fair. Proceed, start, Merlyn. Start your examination.
So coming to my general examination, the patient was examined in a well-lit room after taking her consent and explaining the procedure. The patient is conscious, cooperative, and well-oriented. She is averagely built and nourished and well-hydrated. She had an ECOG performance score of 1. Her weight was 60, height 155, BMI of 25. Her vitals were stable. She had no pallor, ictus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Coming to a per-abdominal examination, after obtaining consent and exposing the patient from the nipple to the mid-thigh, the patient was examined in supine position. The abdomen appears distended. There is fullness in the lower abdomen. The umbilicus is central and inverted. There are no visible scars, sinuses, or dilated veins. No visible pulsations or visible peristalsis. The respective quadrants move equally with respiration. There is no evidence of fullness in the renal angle. The external genitalia and hernial sites appear normal. Coming to palpation, the inspectory findings are confirmed on palpation. The abdomen is soft. There is no generalized tenderness, scarring, or rigidity. There is no localized tenderness or rise in temperature. A 10 by 10 centimeter mass is felt in the lower abdomen, occupying the left iliac, the left lumbar, the umbilical, and the hypogastric regions. The lump is smooth, firm in consistency, non-tender, with ill-defined borders and restricted mobility. The lower extent of the lump could not be palpated. There was no other palpable organomegaly, no tenderness on deep palpation, no evidence of free fluid in the abdomen, no cuff and pulse at the hernial sites. The abdominal girth is 70 centimeters at the level of the umbilicus, no spine tenderness, and no evidence of any supraclavicular lymphadenopathy. Coming to a genital examination, the external genitalia appeared healthy. The urethral orifice appears normal. On PV examination, the cervix and vagina is healthy on palpation. The mass can be felt along the left and anterior fornix on bimanual palpation. On per speculum examination, the vagina and cervix appear healthy. On PR, the pelvic mass is palpable. There are no palpable nodules in the pouch of debris. The rest of the PR findings are normal. On percussion, there's a dull note over the lump. There is no evidence of shifting dullness. The liver span is 13. On auscultation, normal bowel sounds are heard. Systemic examination was normal. On breast examination, there was no evidence of any lump or axillary lymphadenopathy. So after examination, I would like to summarize. A lady age 55, P2L2 with history of TL presented with complaints of pain and distension of the abdomen since 2 months, associated with loss of appetite and loss of weight. On examination, she had a 10 by 10 centimeter mass arising from the left side of the pelvis, which was smooth, firm in consistency, and had restricted mobility.
Could you just go to your first slide on general examination? Sorry, Merlyn, I missed it. Sorry, just can you
Yes.
move to the general examination?
Yes.
Okay, so this is what you said. Now, if it's an abdominal, you don't examine any other system?
I mentioned that after.
No, you have a lady with a
Okay.
low abdominal mass, which you thought of as ovary right from the beginning. So what are the other systems you need to examine, Merlyn? What about the breast examination? What about the respiratory examination? I mean, they're very cardinal, no, to this
Yes, ma'am.
diagnosis?
Yes, ma'am. I
Why the
mentioned it after the
You mentioned
abdomen.
it. You mentioned
Yes,
it. I may have. Please, you have to. It's
Ma'am,
preferable.
yes, ma'am. Systemic
No,
and breast examination.
preferable when you before you do the I mean, finish the
Okay.
systemic examination. I mean, local examination. Please highlight the no point, no harm in repeating. Repeat the neck, repeat the breast, and in this case, the respiratory system. Presuming
Okay.
they all are normal, huh?
Yes, ma'am.
Okay. Fine. So you could go to the diagnosis. I want a couple of clarifications. You said the mass is ill-defined, but you gave a measurement of 10 into 10. That doesn't gel well. If it's such an ill-defined mass, how did you measure it? Number one. Number two, you said the mass is smooth and firm. Okay, by firm you mean it's a solid mass or a cystic mass? Did you mention that in the consistency? Firm is consistency, I agree. A 10 cyst can also be firm.
Yes.
And third thing is just clarify the in your pelvic examination, you did not mention the uterus at all. You said the cervix and vagina is healthy, and you felt a mass in the fornix. Now I want to comment on the uterus.
Okay.
Okay, and I just want to see the last examination slide again. Okay, fine. Go ahead. You just answer these questions. And the other thing is, Dr. Merlyn, you said 10 into 10. So you meant 2 dimensions, right? Vertical and horizontal.
Yes,
when,
ma'am.
when you can't see the lower border, it's difficult to measure.
Yes, ma'am.
Said you can't feel the lower border, but you said you felt it in the fornix, right?
Yes, ma'am.
Yeah, so you may get away with it. If you can say it is 18 weeks or 16 weeks. That's another way of describing. You're quite certain it's a ovarian mass or a uterine mass. Okay, can you just clarify these few questions I asked you?
Yes. So in the breast examination,
sir is asking something. Sir is asking.
Yes.
No, proceed, Merlyn.
Okay. Should I go to the investigation?
Madam asked you to clarify.
Did you mention the groin?
Okay, yes.
Inguinal node you mentioned?
No, ma'am. Yeah.
That's what I wanted you to show the slide again. You can't forget inguinal node. You can't just say I've said generalized lymphadenopathy. So when we have localized on the ovary, or you need to specify the inguinal node. Okay.
Yes, ma'am. Yes.
Yeah, the consistency is firm. You said, is it cystic or a solid mass?
It's a solid mass.
It's a solid. It's solid, but it is smooth. Okay.
Smooth. Yes, ma'am.
You said smooth but solid. Okay, fine. What is the mobility of the mass?
It's a restricted mobility, ma'am.
Restricted meaning what? It's fixed, is it? It's not moving at all. What is its inherent movement? Number one. What is its association with the uterine movement? These two things you have to say in any pelvic mass, abdominal pelvic mass.
Okay. So the mass is on vaginal examination. The mass was felt separately from the uterus. The uterus.
Okay, you can feel
they were independent. Yes, independent. Yes,
so if you move the uterus, what happens to the mass?
There was no movement.
There was no movement. Okay. So you're saying it is an adnexal mass.
Adnexal mass, yes, ma'am.
Okay, okay, fine.
And the borders were ill-defined, but approximately 10 by 10.
Approximately 10 by 10. Did it cross the midline?
No, ma'am.
It does not cross the midline.
It's not crossing the midline.
Merlyn, is it palatable or is it bimanual palpable or not?
So the mass was palpable bimanually and it had restricted mobility. But I could not appreciate the ballotability because of the restricted mobility.
What bimanual palpation are you referring to, Merlyn?
Per vaginal and per abdominal.
Oh, that bimanual palpation. And
Yes.
ballotability? Which ballotment you're referring to?
The internal ballotment of, or the external ballotment of the adnexal mass.
Did sir ask for that? Could you just check with him whether that was the answer he wanted? Huh?
Yeah.
Okay, fine. Continue. So what's your diagnosis? You clarified those questions. Okay. Right. What's your diagnosis? Given the findings you have presented to us.
Most likely it could be it's a left adnexal mass.
Left adnexal mass. Okay.
So what is the possibility?
It could be ovarian mass, ovarian mass.
No, you are considering as a benign pathology or a malignant pathology?
A malignant pathology. A malignant pathology considering her age and the duration of her symptoms.
And what clinical findings are suggestive of malignancy?
Restricted mobility and ill-defined borders.
Okay.
And it's solid also, and it's firm, so it's a solid mass. That also would point.
So it is felt well in the lumbar, iliac, and hypogastrium, right? From what you said.
Yes.
What are the other differentials of masses that you may feel in that area, which you may not feel in the fornix? You also said you can just feel it in the fornix. So are there any other differentials you would like to think about, or it's only ovary?
A uterine fibroid could also be a differential.
Yeah, for most of
fibroid, yes.
For most ovarian masses, a uterine mass is a thing, unless they have the standard omental caking and also. And you also said smooth and firm. So I think that's something you have to. Any other non-gynecological masses? Only gynec. DD is for ovary is only gynec, is it?
No.
What masses can you get there? Solid, ill-defined. I'm also saying it's not felt in the fornix. What can you get?
You can get a desmoid tumors also.
Desmoid. Desmoid is in which plane, ma?
Abdominal walls.
This is abdominal wall, no? With the same findings, but without a fornix.
With the same findings.
Same findings, but not being felt in the pelvis.
A mesenteric cyst.
Now you're treading on dangerous waters. A mesenteric cyst will be cystic. The movement will be classical across the attachment of the mesentery.
Yes.
It won't be solid. It won't be ill-defined. So mesenteric cyst doesn't fit into this.
So how do you proceed now?
I would like to do a sonography of the patient as an extension of my clinical evaluation.
So what are the features that you look for in the sonography?
So I would first want to know the organ of origin. If this is of an ovarian origin, I would like to see if the cyst is solid or cystic. If there are septations in the cyst, if there are any solid components. I would also like to look for the presence of free fluid in the abdomen, the presence of omental nodules, if there are any pelvic or paraortic nodes.
Any other ancillary investigation you carry along with ultrasonography?
I would also like to do a CA-125 of this patient.
No, along with ultrasonography.
Chest X-ray.
No, an extension of the ultrasonography. Do you look for the color flows?
Doppler, yes, sir.
Okay. So how does that help you?
It will tell us the vascularity, and it will also help us to know if it's a benign or a malignant.
So is there any scoring system for that? Okay, if you are not aware, it's okay. You tell you are not aware, okay? We'll move on to the next one. There is a scoring system. We divide into 0 to 4, and then 4 is a strong flow, which is suggestive for malignancy.
Yes, sir.
Okay.
So, Merlyn, is it usual that you always do an ultrasound first? You've given a diagnosis of an ovarian mass. How often would you use ultrasound, and how often will you do CT as your first investigation, given the findings that you told us?
We could directly do a CT scan with contrast also, ma'am, in this patient.
Okay, fine. Continue. So you'll do an X-ray, you'll do an ultrasound, and a CA-125. What are the reports? You have the ultrasound pictures?
No, ma'am. So this CT and sonography was done outside, so I don't have images of both these.
So ultrasound is showing moderate free fluid.
Yes, ma'am.
Did you pick that up on clinical examination?
No, ma'am. No, ma'am.
Clinical examination should find out moderate free fluid. Which is the best? What is the clinical sign that you will do?
Shifting dullness. Fluid drill and shifting dullness.
If it's truly moderate fluid, should have found it anyway. So omentum appears thick and heterogeneous. Okay. What did the CT show? You have the films?
No, ma'am. Not this CT. I have the post chemo. I have CT images of that.
Okay, fine. Oh, it's okay. Yeah. Go ahead. Just
so,
read.
Yeah. So there was a large, well-defined heterogeneous mass lesion in the left adnexa extending into the left iliac fossa, measuring around 10 into 8 centimeter. The left ovary was not seen separately. The mass is extending into the surrounding mesentery, and the ilial loops are in close approximation. There are multiple heterogeneous enhancing peritoneal nodules in the bilateral iliac fossae pelvis and in the left hypochondrium in the lesser sac, also measuring around 2 into 2 centimeter, 2.3 into 2 centimeter.
Okay. Fine.
CA-125 was 435 units per ml. USG guided aspiration of the ascitic fluid was done, which was positive for metastatic adenocarcinoma.
Aspiration mean you made a cytology or a biopsy?
A cytology, ma'am.
A cytology.
Yes.
You don't prefer to do a biopsy? I agree. Earlier we were all doing cytologies only, but last couple of years or more, I think we attempt to do a biopsy, particularly when you can see masses and peritoneal nodules like these. Anyway.
What is the advantage of doing biopsy, Merlyn?
In a biopsy, we get a more, the positivity rate of a biopsy is much better than an FNEC. And sometimes the ascitic fluid could be non-malignant, so then a biopsy would help us in that. And also, if we want to do molecular testing, of course, the biopsy would give us an adequate specimen for that.
So the stratification of the tumors, the low risk or high risk is better with the biopsy. Okay, along with that, molecular studies. So, go ahead.
What molecular studies, Merlyn, that you're looking at this stage?
The genetic testing for to rule out hereditary breast ovarian cancers. We would do.
What is the best sample if you're looking for a hereditary breast or ovary? Would you send from the tumor or would you send a sample of blood?
From the blood.
Blood. It's a germline mutation.
Yes, germline mutation.
Blood. I don't think the reason to do a biopsy is only that. You need to know what type of a cancer. There is a small possibility that exactly it always preferred today most people who give neoadjuvant therapy, both oncologists, surgical and medical, want a biopsy to be done. Unfortunate, sometimes they turn out to be mucinous cancers. They look at rethinking the standard Taxol carbo. Then a very few of them could actually come as a Krukenberg tumor, despite having no symptoms. So it is preferred to do a biopsy. Cytology is what we did a decade or two earlier. Today, I think we've moved to biopsy. Another question to you is, any other serum markers besides CA-125 that you would do?
I would also like to do CEA.
What is a CEA and why is it done?
To rule out colonic origin. So we do the CA-125 to CEA ratio. If it is more than 25, it would be suggestive of an ovarian pathology, a primary ovarian pathology.
Okay. So have you done a CEA for her?
No. Yes, ma'am. Just 1.5. It is normal.
Okay, fine. What is the role of CA-19.9?
CA-19.9 is elevated in mucinous carcinoma.
Okay. Fine. Continue.
So the patient was then given 3 cycles of chemotherapy. After chemotherapy, CA-125 levels had dropped down to 11.7.
What chemotherapy, doctor?
3 cycles of IV paclitaxel at 3 weekly intervals.
3 weekly paclitaxel, yeah. And
yes.
carboplatin. You know the dose?
Yes, ma'am.
Yeah, tell me.
Paclitaxel 175 milligram per meter square and carboplatin AUC 5.
Okay, so this was given for 3 cycles.
Yes, ma'am.
Okay.
Yes, ma'am. And her CA-125 values had decreased. It was done after each cycle. So initially it was 400, then it dropped down to 200, then 100. And after 3 cycles of chemotherapy, her CA-125 was 11.7 units per ml.
So it is normalized, no? It's gone to
no,
11.
Yes, ma'am.
Okay, fine. So examination you people do, or you all just listen to the CA-125?
No, we examine.
What's the finding at the completion of 3rd cycle?
So the lump had decreased significantly. It was only palpable on a bimanual palpation.
It was only pelvic.
Okay. It was only a pelvic. It was now pelvic only.
Okay.
Yes.
So, what do you plan to do?
So we did a CT scan.
Okay. You repeated the imaging.
We repeated a CT scan in which the lesion had significantly decreased in size. It was now a large, well-defined, irregularly marginated soft tissue density mass in the left adnexus of approximately 4 into 5 centimeter. The left ovary was not seen separately. On post-contrast imaging, it showed moderate enhancement. The flat planes with the adjacent structures is maintained. The right ovary is normal. There were ill-defined, irregular, heterogeneously enhancing soft tissue lesions studied within the omentum, the bilateral iliac fossa, pelvis, left hypochondrium, and bilateral lumbar regions. There was minimal pelvic ascites, and there were few small enhancing nodes in the para-aortic, aortocaval, internal, and external iliac stations.
Okay.
So the patient is going to be. I would like to now do cytoreductive surgery for this patient.
Sorry to interrupt you. See, your initial diagnosis is a metastatic adenocarcinoma. Any further investigations were carried out, or the patient went ahead with chemotherapy?
We did a CT chest.
No, that's okay. Okay.
Any IHCs?
No, ma'am.
So you meant that, sir, or you asked something else?
I meant that. Is it necessary to do an IHC in this patient?
What is the panel you will do for adenocarcinoma?
A RAS, BRAF.
I asked for simpler answers. CK7, CK20,
CK20,
So when you have this kind of an appearance, when you're not sure, you have to get a IHC done.
Yeah, a WT1 and PAX8 to know.
Exactly.
Was it done? Origin. No, ma'am.
Preferred.
Preferably, it should have been done. Yes.
Okay. So now what is the plan?
Now I would like to interval cytoreduction.
Interval cytoreductive surgery. Okay. Why do you want to do it now? Why don't we do it after 6 cycles? We'll get more response. Why do you want to do it, schedule it between chemotherapy? What's the logic?
Now, first the CA125 has decreased back to the normal range. Even the lesion has become now much smaller in size. So it is operable. Even the other mental caking has decreased. So now there is a very high possibility we can get optimal cytoreduction. So we could go in with surgery. More 3 cycles would not give us any more beneficial effect.
Oh, so you either operate at 30 cycles or you never operate. Is that
No,
so?
we can. There is. We can give. So it's recommended that after 3 to 4 cycles we should go in for surgery. However, if you want, we can consider the possibility of 6 cycles, but it's not generally done.
Haven't you seen patients who are not in your purview, inoperable at third, and they become?
Then we give for such patients under. Yeah, it's according to our own discretion that we can continue give all the 6 cycles pre-surgery.
But what I am specifically asking you is, what is the particular reason why you sandwich the surgery before 3 chemos and you still give 3 chemos after the surgery? You understand my question, right?
Yes, ma'am. So that after optimal cytoreduction also we have chemotherapy for the microscopic.
Yeah, exactly. That's the writing reason why you are doing it at 3rd or 4th, whatever, not doing it at 6. Okay.
Yes.
So what's the extent of interval cytoreduction you expect given the initial and current CT films? And can you name 2 trials which compared interval debulking versus primary debulking? Quickly just tell us the salient trials and what the findings were.
Sorry, ma'am, not it.
Okay. You should read, men.
Yes, ma'am.
There's no excuse for not doing that. Okay. Right. Yes. So you will. What extent of surgery are you looking at?
A total hysterectomy, and we would like to do a total omentectomy for this patient. And wherever there were pre-chemo, wherever there were peritoneal lesions, we would like to remove all of that also. So we would consider doing a peritonectomy, a pelvic peritonectomy for this patient.
So you'll do a peritonectomy, you will do a total hysterectomy, you will do an omentectomy.
Yes, ma'am.
And
nodal dissection in case it is, because this intent over here is cytoreduction, we would only do nodal dissection for suspected nodes or enlarged nodes.
Okay, she seems to have some enhancing nodes, no, in the retroperitoneum and in the pelvic. So you'll probably address that as well.
Yes, ma'am. Yes, ma'am.
Oh. So once you just tell us the steps of the procedure.
Okay, so we take a vertical midline incision extending from the Zipfi stomach to the pubic symphysis. After opening the peritoneal cavity, we'll take a peritoneal, a wash will be taken, around approximately 200 cc of normal saline is instilled into the abdominal cavity and then aspirated from all different quadrants of the abdomen. Then we examine the peritoneal cavity to examine the extent of the primary disease and the extent of peritoneal nodules. We will check the diaphragmatic surface. We will check the liver for any parenchymal metastasis. Then we would like to. Then I would like to proceed with the hysterectomy, and then after that, the nodal dissection and the peritonectomy. Then a total omentectomy for the patient also.
Merlyn, yes. Merlyn, I have 2 issues. One is, Would you do a laparoscopy or not in this patient? A diagnostic laparoscopy?
So considering there were a lot of omentum caking also involved, I would prefer to go ahead with a laparotomy.
A laparotomy.
Yes, ma'am.
So regardless, supposing you find on laparotomy there is peritoneal carcinomatosis, PCI score is close to 22, you will anyway go ahead with the surgery. You've decided, so you will just operate regardless of the finding, is it?
No.
Then?
No. I will use the CT to determine how much.
How accurate would CT, ma? How accurate would CT be to assess peritoneal nodules which are less than 5 mm?
Not accurate.
No, I just want to clarify one thing. So you will operate regardless of the peritoneal burden, is it? Is that the understanding?
No, ma'am. No.
So when will you not operate this patient? You have told what you will operate. When will you not operate on this patient? Whether you've done a DLAP or a laparotomy?
If there are mets in the liver, if there are more than 2 centimeter lesions over the diaphragm, if there are nodes, if there are periportal nodes which are present, if there is disease at the root of the mesentery.
Agreed. There are a lot of multiple nodules on the small bowel. All those things you will not often.
Yes.
Okay, but I think, like sir told, I think a DLAP is not a bad thing to assess before you make a long incision.
Yes.
Second thing, you mentioned you will do a peritoneal cytology in this patient with the lavas.
Yeah.
What is the purpose behind that?
Exactly. Already studied peritoneal nodules.
Yes.
Why do you need cytology?
We don't need it just as a.
She has ascites. Once she has ascites, the peritoneal lavas doesn't hold true. Okay?
Yes.
And okay, fine. So you will do the. Then what else will you do? Why do you do a hysterectomy in ovarian cancers? What is the logic? You expect it to harbor cancer, endometrial cancer?
It's a very less chance, but.
Then why do a hysterectomy? Just remove the ovarian mass. If you want to remove the other ovary, of course the tubes you have to remove. You said the site of origin is the tube, so tubes have to come out. So why is
there's no advantage of.
Pardon?
There's no advantage or any use of preserving the uterus.
There's an advantage of removing it. That's the way to answer. The answer is you can have synchronous malignancies. Number 2, there is a cover of peritoneum over the uterus. So by just doing a hysterectomy, you're removing that as well. Part of your peritonectomy.
Yes.
Okay. So you said that you will remove the enlarged nodes. You may not do a formal dissection, correct?
Yes, ma'am.
Okay. So after the surgery, how assuming she's had disease everywhere from wherever you have described, what is your further plan?
No.
Sorry.
Merlyn, what is the intent of the surgery? What should be your volume of residual disease?
So optimal site reduction. There should be no visible gross macroscopic disease.
So CC0?
CC0, yes, sir.
Okay, that should be your objective. So how do you define an optimal cytoreduction?
So optimal cytoreduction is defined as when the total residual disease is less than 1 centimeter.
Okay, why do you do the cytoreduction at all first? What is the principle behind cytoreduction?
To decrease the total burden of the disease.
So what will happen with that?
Chemotherapy will be more effective. It has been shown that maximum cytoreduction gives us a better overall survival, progression-free survival.
That's okay. The principles behind that, can you tell us the cell cycle relationship, the vascular pattern, what happens? This is a mode of relevance in the primary cytoreductive surgery, but it has relevance here also. Are you aware about the biological principles behind cytoreductive surgery?
What order kill will you get if you do surgery? Cell cycle? Merlyn, you're there?
Yes, ma'am.
Okay, okay. You have to go read.
Yes, ma'am.
Very specific question sir has asked. Why you said less than 1 centimeter is considered optimal? Why is it put at 1 centimeter? Isn't it no residual tumor today? Today the definition of optimal
Today, ASCO
cytoreduction-
has, now ASCO says that it should be no residual
maximum cytoreduction. You don't
Maximum.
leave any residue. Okay.
Yes, ma'am.
But why was the cutoff earlier at 5 and even prior to that
1.
10 mm? There's some reason, right? So go read up today.
Yes, ma'am.
So you have done assuming you've done an optimal cytoreductive surgery, patient recovers well from the same. What is your further plan?
I would like to give her 3 more cycles. I'd like to give her adjuvant chemotherapy.
How many more cycles
3 more cycles of adjuvant chemotherapy.
of Paclitaxel?
Yes, yes, ma'am.
Okay. So at the end of the completion of treatment, what do? Do you repeat a CA-125 at the completion of treatment?
No, ma'am.
Not needed. Okay.
Not
After
needed.
treatment is over, how do you follow her up?
We follow her up every 3 monthly for the first 3 to 4 monthly for the first 2 years, and then 6 monthly for the first 5 years, and after 5 years, annual follow up. And on the follow up, we would do a CA-125, and symptomatically, whatever investigations, we would do a sonography of the abdomen and other symptomatically oriented investigations.
What are the current thoughts about CA-125 for follow up? There's been a trial also that changed the perspective in a way. So, what is the current thoughts? Is it useful?
So in some cases, there is only CA-125 elevation, but there is no actual evidence of recurrence. So in such cases, it is said that only if there is actual radiologically picked up recurrence, we should start treatment. The treatment should not be only based on the levels of CA-125, and we have to check the trends of the rise in the CA-125 on her follow-ups.
Has it been proved that if you follow up patients with epithelial ovarian cancer with serum CA-125, you're improving survival?
No.
It's the reverse. That has been proved.
No. Yeah.
Yeah, so I think before you offer CA-125, it is fair that you tell the patient, we don't know if it's going to help you. You have an option of using it as a follow-up marker.
Yes.
Agreed?
Yes.
What are the chances of relapse given this finding that she had?
She would be stage 3, so then she has an 80%, 80% chance of recurrence.
80% chance of recurrence happening in usually?
In the first 2 years.
First 2-3 years. Okay. So she has a 20% chance of living over 5 years, right?
Yeah.
Right, okay. Now,
how do you reduce the chances of relapse?
In case we had, if molecular testing was done and this patient had BRCA mutations, we could consider maintenance therapy for her.
What maintenance?
With olaparib, with PARP inhibitors.
How long would you give them?
Till progression.
Okay.
300 milligram per day till progression.
Fine.
So Suppose she cannot afford those costs. Any other alternatives?
In some patients, if bevacizumab has been used in the neoadjuvant, that is also considered, it can be given for maintenance therapy.
So it's an option. Okay?
It's an option, yes.
So what are your thoughts on HIPEC? This is a patient who has peritoneal disease, who's optimally cytoreducible. So what is the status of HIPEC in ovarian cancer?
There is advantage in if we think about the OV HIPEC trial. There has been shown that if along with interval cytoreduction HIPEC is given, there is improvement. There is increase in the progression-free survival as well as the overall survival.
How much has it improved? How many months?
6 to 7. I'm not very sure.
They have mentioned.
Yeah.
So you're from a
It's
center
6
that
to
does
7.
not practice
6.
HIPEC. 6 months.
Yeah. No, we don't.
You don't practice. Okay, fair enough.
No, very fair.
When would you do a secondary cytoreduction? What are the indications to do secondary cytoreduction?
So in case, so first it has to be operable next, and the patient, it's preferable to be done in platinum sensitive patients.
What is the definition of platinum sensitive relapse?
If they have a disease-free interval of 6 months after platinum therapy.
6 months itself is platinum sensitive?
If
What
the
is
disease relapses more than 6 platinum sensitive is if the disease relapses after 6 months.
So before 6 months, if somebody relapses, what do you call them?
It's platinum resistant.
What is platinum refractory?
Platinum refractory is when you see that there is remission and then again it reoccurs within 6 months.
What is potentially platinum sensitive? You'll have to go and read.
Yes, ma'am.
So what's the role of the minimally invasive surgery in ovarian cancers?
It can be done first for staging if we want to, for biopsies, for diagnosis, if we want to check if the patient is a candidate for primary debulking surgery, that can be evaluated, or if we should give a neoadjuvant chemotherapy for that.
So can we do a cytoreduction with MIS?
It can be done, yes, sir. It can.
Who are the group of patients where it can be done?
So stage 1 A and B cancers and low grade tumors.
No,
Low
very,
grade serous.
very early cancers.
Stage 1.
Selected group of patients who received IDS, interval following chemotherapy. But
Yes.
generally, the preferred method of treatment is open surgery.
Yes, sir.
Okay.
See, minimally invasive surgery is usually used in a setting, more used in a setting where patient has had a ovarian tumor removed which has come as malignancy, and then you're doing a staging procedure. So there, I think, to do all that is very classical. Then also what sir said, if you have a good response and it is feasible to do MIS safe.
Yes.
Suppose this patient had got involvement of the colon
One more question.
or small intestine, what will do?
Yeah, you have any doubts you can ask us?
I would.
Anybody?
We could go ahead with bowel resection. It would be an ultra radical.
So, Merlyn, I just want to know. So, the patient is planned for surgery at this point, is it?
Yes, ma'am.
Is it so?
Yes, ma'am. Yes, ma'am. She's planned for surgery.
She's planned for surgery now?
Yes, ma'am.
Okay. And the findings that you told us are findings that are recorded in the case record, right? The what you presented as 10 into 10 and all that. No, I'm just
Yes,
for my clarification.
yes, ma'am. Yes, ma'am.
Okay, okay. What clinically now? What does she have? Clinically, have you seen her?
Yes, ma'am. Now the lesion is purely pelvic.
Okay, fine. Then
Yes.
you should have presented that only. You shouldn't present the upfront finding.
Okay.
You should present
Yes.
this, and when asked, you should say that was the initial finding. It's okay. Doesn't matter.
Okay, ma'am. Okay.
Your voice is quite feeble now. Sir, we take questions, sir.
Yeah, I think there are two questions. I think, does the peritoneal wash has any significance? No. In this particular patient, no. It is generally done when we are doing an upfront for an early stage disease in the absence of ascites. Second question is regarding the duration of olaparib. I think the recommended duration is 2 years. I am not too sure. Anyone, Somshekar can, Sridevi, anyone of you can
Current recommendation is 18 months to 24 months as an adjuvant setup.
Yeah.
And if it is in recurrent setup, either progression. But adjuvant setup is 18 to 24 months.
Okay, Merlyn, can you comment on this? Is there any role for RT in any ovarian cancers? Are you still with us? No.
Yes, I'm there, sir.
Can you, somebody asked the role of radiation treatment in ovarian cancers.
In case of recurrent lesions which are not operable, we could consider radiation.
Okay, for palliative
And
purpose.
for palliative purpose and for like
Anything else?
oligometastatic bony lesions as symptomatic, palliative only.
In any other condition where it has proven to be much as an adjuvant setup?
No, sir, I'm not aware.
So sometimes they use in the granular cell tumors, patients who have got an advanced disease who underwent a cytoreduction.
Okay, sir.
The option is radiation treatment.
Okay, sir.
Yeah, the question, I think both sides. So, what is internal palatability? How do you differentiate palatability? Is it
Yeah, but they are all talking.
Yeah, one question is what is internal palatability? How is it different from external palatability?
Okay, Jen, what you do is you put a finger in the vagina and feel the movement of the compress against it. You will feel the finger. That is in general in the pregnancy when you want to see the fetus movements. So press against the uterus, you will feel that is the uterus. So the external development is you put the finger inside, put the other hand on the abdominal wall, see whether the mass touches the hand or not. That is the external development. And that has got some relevance. These techniques are no longer generally widely used in clinical practice with the advances of the imaging investigations, but they have a relevance in general in the obstetric practice.
Next question is what is second look laparotomy?
Second look laparotomy is basically generally nowadays we are no longer carrying out. It is done only in a selected patients when you are running clinical trials to assess the response to the treatment and then take out the samples for that purpose. But otherwise, for clinical practice, second look laparotomy is no longer practiced.
Do we have to do systematic lymph node dissection? So there are 4 or 5 questions related to that. In stage 2 node negative anyway, they are going to receive adjuvant chemo. Why do systematic lymphadenectomy?
So primarily for a staging purpose. In more advanced cancers, it's only for debulking a cytoreduction purpose. So the Lion trial has shown that there is a high incidence of nodal disease, but it doesn't add to the life of the patient.
And next question is is there any role of tamoxifen as maintenance therapy? Manish has asked.
So tamoxifen as a tool is of great some relevance in low-grade serous tumors, because low-grade serous tumors these days we are treating primarily with the adjuvant hormonal treatment, generally the letrozole or any one of those drugs. Some people are using tamoxifen also.
Next question is whether is staging lab a must before offering NSCT?
Sorry, can you repeat it?
Is staging laparoscopy mandatory before starting a patient on neoadjuvant chemo? I think the logic what Kalyan Singh asked is, we start on neoadjuvant chemo, we actually don't know the PCI, and then we come back operating, everything looks normal.
So it's not mandatory.
Correct. Only in clinical trials we do it as of today. Otherwise, imaging is, you go by imaging, a good contrast enhanced CT scan, and then that's it, you document, and then either way you're going to operate. There is one more question student have written. Mahesh, what is the logic behind leaving 1 centimeter following optimal reduction? I think Mahesh, you got confused totally. No disease should be left in ovarian cancer. Reduction is CC0, no macroscopic disease. Having said that, there are some areas like, if you are in the deep liver hilum where it has gone into liver hilum, or it is stuck to the vena cava, or there are some areas like diffuse small bowel serosa, micronodular disease. So even if you are not able to achieve no macroscopic disease, at some areas where you will not be able to remove it, like small bowel multiple nodules, even then it is found that optimal cytoreduction happen, survival benefit happens up to 1 centimeter of disease as per GOG. So even you should remove all the disease. If it is an area where if you remove lot of functional problem is there or it is not resectable, then up to 1 centimeter by mistake, if you left it or left because of technical reason, still that patient has a overall survival benefit both by cytoreduction as well as HIPEC. That is what we meant. If you are able to leave more than 1 centimeter disease, then there is no survival benefit nor HIPEC helps. It becomes palliation. Raju and Sridevi, you want to add anything on this?
Yeah, I agree with that. Ideally, should be CC0.
Definitely, but the earlier things, like you're talking about the 1 centimeter, no, Somshekar?
Yeah, that is what student asked. Yeah.
Okay, yeah. I think now it is maximum cytoreduction. No residue to be left behind.
Absolutely. So GOG trials until year 2005 used less than 1 centimeter cytoreduction as optimal, where survival benefit was found by all the trials. Then it was modified as no macroscopic disease. So remember, what is optimal cytoreduction? No macroscopic. But if the answer from examiner is up to what level cytoreduction overall survival benefit comes, up to 1 centimeter it comes. But no macroscopic is superior to 1. Beyond 1 centimeter, all of them fall into one group. Neither they have survival benefit nor they have benefit from HIPEC. That is what it is meant. That's something. Second question, Santosh has asked, is there a cutoff of PCI in ovary? Unlike stomach, colon, like in stomach beyond 7, PCI 7, they have no survival benefit. Colon beyond 15 PCI, there is no survival benefit even if you achieve CC0. Like that, is there a cutoff PCI in ovary?
There is no cutoff.
Yes. That is the beauty of ovary. Remember, CA stomach with peritoneal disease technically is stage 4. CA colon with peritoneal disease is stage 4. Peritoneal disease in ovary is still stage 3C. Which means if you can achieve optimal cytoreduction, PCI is not a contraindication to have overall survival. PCI in ovary is not a prognostic indicator as long as you can remove everything, but an indicator of the morbidity and mortality of the surgery. Where do you ask colonoscopy and endoscopy in which cases? Yogesh has asked. In CA ovary, where colonoscopy, upper GI endoscopy has to be asked.
I think we answered that question in between, no? When the CA 125 CA ratio is less than 25, or if the patient has GI symptoms.
Absolutely. And any patient with bilateral ovarian tumor, when you may not be very sure if it is Krukenberg from other place. So these are some of the areas I agree. But the best way is to look at CA125 CEA ratio or bilateral ovarian in young women. You may do the endoscopy to make sure it is not extra ovarian pathology.
Or when the patient has a mucinous histology.
Yes, you're right. Absolutely. Even though quite often it could be appendix, it may not have been seen, but it is possible. There are many questions, but it's difficult to answer all of them. Hundreds of questions have suddenly come. One more question is, when should you do total parietal peritonectomy and selective? Remember, as of now, where entire peritoneum has to be removed as per evidence is PPPC, that is primary papillary peritoneal carcinomatosis you do, mesothelioma we do, and the peritoneal pseudomyxoma we do. Otherwise, in all other cases, as of today, evidence-based, it is selective disease-based peritonectomy. In exam, if somebody asks when did you do total parietal peritonectomy, the answer is primary peritoneal carcinomatosis, mesothelioma of the peritoneum, and high volume pseudomyxomas. In all other cases, it is not mandatory, even though studies show a trend of better DFS and less peritoneal recurrence if you do total parietal peritonectomy in a CORI after NACT. Raju and Sridevi, anything you want to add in this?
Yeah, I agree with that.
I fully agree.
So there are many other questions, but we'll keep something for other class. We are already overshot by 10 minutes. Fantastic.
Okay.
Yeah.
Okay.
This actually shows, Raju and Sridevi, how fantastic class you have taken and how interesting this topic and so much little our students know. And I'm really worried that tomorrow if they get this case, we as an examiner feel sorry and sad that they're not answering and we are not taught them well. So maybe after 6 months we'll repeat a similar case. So it might help.
Sure. Definitely.
Any concluding thing, Sridevi and Raju, you want to add before we hand over to National Board?
Yeah, I think Merlyn did quite well. I think she needs to brush up a few things about the basics. Otherwise, she did quite well.
I fully agree what sir said. She'll have to brush up a few things like cell cycle,
Yes.
the mechanics of this chemotherapy she has to cycle. And she has to also have an open mind when, every mass in a lady or every distension is not ovary. So you should be at least, in a position to offer differentials. So that I think you should keep an open mind.
Yes.
Right?
Yes.
Otherwise, you did well, Merlyn. Keep it up.
Thank
And Merlyn, another thing is, suddenly you go into this breaks of silences. In exam, please don't make silence. I'll tell you, me and Sridevi in examiner together, whether you like it or not as an examiner, silence and a pause for a long time we perceive as you don't know that. You may be introspecting, you must be doing Chintan Manthan in your mind. Even today I noticed, suddenly you keep quiet and you say monosyllable, yes, no, okay madam, no madam. We perceive that as you totally are not having clue what's happening. Please communicate. If you don't know, you say I don't know and move on, but don't give monosyllable, yes, no, okay. If a examiner asks a question, it's not that they don't know. They want to know your thought process. No thought process can be told in monosyllable. You almost ended up the whole discussion when they ask doubts, questions in between your history taking in monosyllables. Don't do that, okay? Be communicative. And the same way, when you don't know, you just say politely, I'm not aware of this. But little communicate. See, exam is a communication between two people. Examiners are asking to know what you know. And if you are at the giving end and you are silent and one monosyllable, it's not good, okay? It's an important advice. Sridevi, you agree with me?
Sure, fully agree.
Okay. Thank you very much. My heartfelt thanks from
Thank you
students,
so much,
myself, and National Board to Sridevi and Raju. Fantastic discussion. Very tough case. This would take 5-6 hours multiple times. As I always tell, the purpose of the teaching program of National Board and us mentors is not to spoon feed you. You are not in first standard, second standard. We write a note and spoon feed you. Our aim is to stimulate your mind, show a direction and the path. Now you have to see so many questions, thought processes given by Sridevi Madam and Raju. You have to go back and read. We can just stimulate your mind, show the direction. We will not spoon feed you to read it. Merlyn, you did well. All the best for your exams. Thank you very much. And over to you.
Thank you, sir. Thank you, the National Board. Bye.
Thank you.
Bye, sir. Thank you, sir. Thank you.
Thank you to respected panelists. We can close the session now.
Can you give us some Kvvn?